Hello, everyone. We'll get started in just a moment. We've got a few more people who will be joining us. There we go. All right, we're going to go ahead and get started. Good afternoon, everyone. Thank you for joining us for the next conversation in Dossier's Nurse Informatics webinar series, EHR Optimization and Usability, a Nurse Leader's Guide to Informatics. Today's webinar is structured as a panel discussion. It is being recorded, and we'll share a link to the recording once it's available, which typically takes a day or two. That email will contain links to the other nurse informatics recordings that Dossier has hosted in the recent weeks. Today, we're diving into an issue that every nurse leader is grappling with: how to turn the EHR from a source of frustration into a tool that supports workflows, engagement, and better care. Before we jump in, I'd like to introduce Dossier's CEO, Geir Arnhoff, to share a quick perspective on why this topic matters so much to our work and to the future of nursing.
Thank you, Amy, and thank you to Nicole and EJ for being here. So at Dossier, we focus on helping healthcare organizations to build a strong and confident team through digital competency management. And as informatics continues to evolve, it's clear that technology should reduce complexity for nurses and all clinicians and not add work to it. That's exactly why we are hosting this conversation, so leaders can learn practical ways to improve stability and reduce the documentational burden and connect technology decisions with real outcome for patients and staff. So we're looking forward to the conversation today and turn it back to you, Amy, to get the whole thing started.
Thanks, Geir. I'm excited to introduce today's presenter, Nicole Duke. Nicole is a board-certified nurse informaticist with a passion for helping nurse leaders create EHR experiences that support care teams instead of slowing them down. She spent her career bridging clinical practice and digital innovation, and she brings a grounded, practical perspective to this work. Nicole, the floor is yours.
Hello, everyone, and welcome. Thank you for joining us today. Another panelist that will be with us here is EJ. She is an implementation specialist that's been in the SaaS environment for over 7 years. She's led multiple EHR implementations, facilitated HL7 integrations as well, and helped with workflow optimization. She's trained dozens of end users and helped implementation efficiency while building strong client relationships. And she also holds a degree in informatics. She has her master's in health informatics from Mercer University. EJ?
Thank you. Hi, everyone. Yes, I'm EJ Ellis. I'm the implementation specialist here at Dossier.
Terrific. So, Nicole, EHRs were designed to improve care, yet many clinicians feel they've added more burden than benefit. Why do you think that disconnect exists?
Yeah, I think this disconnection exists because EHRs were originally designed and implemented with good intentions, but not always with a clinician's workflow in mind. So the primary goals of EHRs were to improve documentation, streamline billing, and meet compliance standards, largely serving organizational goals rather than reflecting the nurses' day-to-day experience and practice. As a result, the systems are often prioritize data entry and administrative tasks over usability and patient interactions. So without that ongoing collaboration between clinicians, administrators, and technology developers, EHR workflows haven't fully aligned with how we actually deliver care. What was meant to make care more efficient, in many cases, has added layers of complexity. And if you've been with me for my other webinars, you know that this is how I got involved in informatics. I was frustrated, especially during COVID, with the workload, unnecessary documentation, and I kind of reached out into other areas of nursing, got involved in informatics. EJ, what are your thoughts on this disconnect between the clinical workflow and EHRs, and tell us about your experience?
Yeah, from my background and perspective from project management and health informatics, I think the disconnect lies with how EHRs were first implemented compared to how clinicians actually worked. From my experience, just doing a lot of go live support and implementation within the healthcare organizations for EHRs, I found that while building out or creating the workflows or templates for the organization, a lot of times the decisions that were made around how things should flow, how the patient's journey should look through the clinic as it relates to the EHR, were more of what the business side of things look like versus how the clinician actually functions and works through the patient's journey along with them. I think when EHRs were introduced, there was a huge push for adoption and compliance, right, to follow along with new regulatory practices and requirements from the government. But I think that with that, we got systems that technically worked, but they didn't actually work as well for people who are using them day to day. So that's kind of where that blocker always lies. I think when we involve clinicians early in the design with the workflow in mind and the understanding of how the product is actually going to be used, we make sure that systems can talk to each other, make sure that EHRs really can become what they were meant to be, which is like a tool to support better care and not just another task on the to-do list for the clinicians.
I totally agree. And you brought up a good point that has been a hot topic over the last several years is what we call in informatics interoperability, which basically means how different health systems or technologies communicate to each other. We want to make sure they speak the same language. So if you think about a patient going through the care delivery system, making sure that all caregivers are informed of what's going on from primary care to specialists, to inpatient physicians. Can you speak to some of the barriers of interoperability and how that's created some disconnect?
Yeah, just like how you mentioned about being able to speak to different systems just within like one healthcare organization. If an organization is using multiple applications that are not talking to each other, that creates a disconnect not only with the end user with being able to efficiently document any patient information, but also the patient's experience with being able to have access to their record and have access to the data that they need to, allow them to be empowered with taking care of themselves, essentially. And I think that that's why clinicians often have to like track down, re-enter data that should already be there because of that disconnect between those systems. So I think interoperability is a huge thing within the healthcare technology space that's still being developed and iterated on just to make sure that all systems can really function the way they should.
Absolutely.
Right. You mentioned how software usability impacts the nurse's experience. Can you expand on what that means for both nurses and the patients they care for?
Yeah, I know a lot of times when I was working in the hospital or even just in my conversations with my fellow colleagues, they think about like, oh, the EHR is such a burden and they complain about it, but and leadership alike. But I don't think we take the time to really dive into what that really means and how it impacts the nurse. Like it impacts the nurse's well-being, patient safety, and overall operational efficiency. So, like EJ was talking about, when systems aren't designed with clinical workflows or end users in mind, it creates a ripple effect that impacts every part of the care delivery process. So, a recent study published by the US Surgeon General said that nurses spend on average 40% of their time on documentation. And I know if there's nurses on these calls, they'll know what I'm talking about. That's almost half of our shifts, navigating flow sheets, entering data into the EHR. And what this really means is less time to assess our patients, less time to teach our patients and connect with them, which is really the core of our nursing practice and what gives us satisfaction with our job. So, as a result, this leads to decreased job satisfaction for us, increased burnout, unnecessary cognitive load. Like we have to think about navigating the chart and where to put things in instead of thinking about and assessing our patients to proactively intervene on potential adverse outcomes. And then, of course, everybody also knows it leads reduced time for basic self-care. Like I'm sure everybody on this call has experienced shifts without lunch breaks or eating meals, bathroom breaks. And then for our patients, the impact is also significant. So there's an increased risk of medication errors, poor patient coordination, so lack of communication as the patient moves from maybe radiology to lab back to the unit. And then that all translates into lower patient satisfaction scores, which impacts reimbursement as well.
Sure.
Speaking of reimbursement, EJ, you've had a lot of experience in billing processing and the financial aspect of what this means for organizations. Can you share your experience with this?
Yeah, absolutely. I think with the implementation and just the regulation of organizations having EHR systems in place, the base, the one of the reasons why was, it was built for billing and compliance, essentially for the business aspect. The idea was to capture data that supported coding accuracy and reimbursement, which is obviously very important not only to the organization, but also to the patient. But when usability isn't prioritized in that way, that same system can actually slow down clinical and administrative workflows, like you mentioned. I think poorly designed interfaces or like even redundant documentation can lead to incomplete and inaccurate data capture, which then can affect like claim submission, denials, and even cash flow for the organization. Like on the front end, that means like nurses spend more time documenting, like you mentioned, to meet billing criteria instead of engaging with the patients, like you said. But then on the back end, it means revenue cycle teams spend more time correcting errors, resubmitting claims, or even like reconciling documentation gaps due to just that gap in the documentation from the end user. So it's all connected. And I think even from the patient's perspective, that ripple effect is real too. In that if the data isn't captured cleanly the first time, then it can lead to delayed authorizations, billing confusion, even higher out-of-pocket costs for them. And then when the systems are intuitive and more like interoperable, that data flow is a lot more smooth from point of care to financial systems. And then that translates to more accurate claim processing, faster reimbursement, and then overall smoother patient experience as well. So I think when we discuss like usability, it's not just as for the clinician's well-being, although it's very important and that is a big issue, but it's a business and a patient satisfaction issue as well. And I think investing in usability is really an investment in operational efficiency, revenue integrity, and then overall quality of care.
I agree. And even just on a personal level, I have obviously a network of friends in healthcare, nurse practitioners, and they talk about how a lot of claims will get submitted. And it's because revenue cycle and the information submitted to insurance companies, they're not necessarily documented in a standard place, leading to confusion. So delays in getting whatever test that patient may need, diagnosis, and then ultimately intervention to make them better.
Okay. You've outlined how usability affects every level of care delivery, from workforce well-being to patient safety. From your perspective, what makes this leadership issue rather than something that sits solely within IT?
I think that's a great question. And before we dive into that, I have a question for the audience too. I'd like you to put in the chat if you have had conversations or have heard conversations from leadership, whether, I guess, if you are a leader or you've been involved on the floor, if you've heard this discussion, like how documentation and EHR optimization impacts patient outcomes, the job satisfaction, retention, and the care delivery process in general. All right, now to answer the question that Amy asked, I think when documentation consumes so much of a nurse's time or physicians, it's not something that can be solely left on IT. It's a challenge that touches everything, like we talked about, how engaged our teams are, how safe our patients are, and how efficiently we deliver care. Ultimately, that translates directly into financial performance. So if I know for the floor nurses on this call, you'll know what I'm talking about, but like for stroke activations, every minute that that patient isn't getting TPA is a minute of brain tissue lost. It's kind of the same thing with healthcare. Every minute that's lost due to poor usability is a minute lost of productivity, revenue, and outcomes that are left on the table. And Amy, sorry, I had a thought, but it lost me. I'm not gonna lie.
It'll come back.
Yeah,
It'll come
it will
back.
come back.
I
It
promise.
always does.
So you guys have shared some great information, but where should nurse leaders start when they want to optimize EHR workflows?
My question came back to me. I was going to see if you could monitor the chat to see if anybody's had any questions and bring those up as needed.
Absolutely.
So what a big topic to cover. So when you think about EHR workflows, it can feel overwhelming. There's all different parts of the chart, different hands touching the EHR. So my advice is to start small with a specific focus area in mind. And most importantly, bring the right people to the table early on. So this will be your frontline nurses, your informatics specialists, educators, and even your IT as well. And then once you have those people at the table, the goal is to really understand your current state. So, what's actually happening at the point of care? Sit with your nurses, watch how they move through the record, identify where documentation is duplicated or unnecessarily complex. It's often those small, repeated inefficiencies that add up to hours of frustration and wasted time. And then from there, I always recommend prioritizing high impact areas that will give you the most bang for your buck. So those daily pain points that can be things like order sets or maybe a specific flow sheet within the patient chart or handoff documentation. When you start small, you can test those improvements in just one department and measure the outcomes before you scale them to your whole organization. So an example of this was back when I worked in the hospital as an informaticist. My informatics team and I used analytic tools built already into the EHR to understand how clinicians were actually using the system. So most of the EHRs out today have this kind of capability. They're tools where they can track specifically how much time a clinician spends in what part of the charts, how many clicks something takes, and where those bottlenecks occur. By leveraging some of those tools and insights, we were able to pinpoint which departments and providers specifically were struggling the most and identify what parts of the charts were creating those inefficiencies. So in this specific case, we discovered nurses were spending large portion of their time in flow sheets. So this is where they document things like their assessment of lines, tubes, and drains, vital signs, your basic head to toe assessment. And with this information, we we basically found out that they were re-entering throughout multiple flow sheets the same information, so maybe chest tube drainage. And we launched a focus sprint with this department specifically and helped reorganize the flow sheet and restructure it to avoid those redundancies and help it align with the natural flow of the patient. So once we finished the sprint, we reanalyzed the EHR data from those analytic tools and compared it to our baseline. And the results were tangible. We consistently saw hours of saved time and documentation. Nurses reported improved flow sheet usability, and they've also reported stronger confidence in navigating the electronic health record.
Wow. Okay. So is there a way or how can EHRs be used for things like hiring new hires? How can that data or information be used?
For hiring new hire nurses,
Yeah.
yeah, I think incorporating this into the competency of initial onboarding would be critical. A lot of times, I think people assume that we're taught like technology and digital proficiency within school. And thankfully, more nursing schools are incorporating this into their curriculum. So, informatics, for example, and of course, with the rise of AI, there will be more about data privacy and ethics. But I think
Mm-hmm.
as a leader, not assuming that all nurses have this basic level of competency and incorporating that into your daily practice would be critical to making sure your nurses are equipped from the get-go.
Okay.
Yeah, that's a great question.
Okay, so you saw real improvements through that optimization work, but sustaining those outcomes long term can be difficult. How do you ensure those workflow changes stick?
Yeah, I think it kind of goes back to what I was actually just talking about with the question. It aligns well with that, is embedding it into our everyday practice. So not treating it as a one-time event. You know, if you've been a part of projects, we're all really excited. There's new things coming on. We see changes, but that can quickly fade. So when I first started as an informatics specialist, one of the most impactful lessons I learned was the importance of governance and accountability. governance is critical for sustaining those changes and creating a framework for it to be embedded into your daily work. It creates a clear framework for decision making. So in my organization specifically, we created a clinical informatics committee with representatives from all key areas. So nursing, physician leadership, IT, educators. And then we even further broke it down into subgroups that focused on particular areas of the EHR. So with physicians, order entry was huge. With nursing, it was focused more on flow sheets. And then these committees would review any EHR data or any process improvement projects going on. We would prioritize any requests that came in for changes to the EHR, and then make sure any changes or proposed projects aligned with both strategic and clinical goals together. Because, like, I know we've talked a lot about how EHRs were designed for billing and administrative and compliance. What I don't want you guys to take away is that it's not either or. We need to have both. We need to have an operational income to keep the doors open. We need to make sure we're meeting compliance standards. Those are in a place for a reason. But we can also consider the clinical workflow for the best of both worlds. And then also, like with the new hires, focusing on ongoing education and competency. So that's really where my work has been focused with Dossier in particular. So currently, I'm a customer success manager here at Dossier, and I partner with healthcare organizations to build this right into their orientation and ongoing competency. So this topic of EHR optimization and digital literacy isn't just a one and done training that everyone sleeps through. And I know you all have, because before I was interested in informatics, I was like, another computer class I had to sit through that was like 2 hours long that I really didn't care about at the time. But working with competency management specialists like Dossier or your educators to design competencies that are meaningful and administered in a way that leads to sustainable change is critical, as well as incorporating digital literacy topics like data privacy, decision support awareness. So more and more EHRs have clinical decision support software in them. So these are tools that may help in the guidance of intervention. So I think about like diabetes application. You may put in a patient's insulin sensitivity and then how much they will use an algorithm to produce a number about treatment or show graphs. And then, of course, emerging technologies like AI, which we covered in our last session. If you haven't watched that, I encourage you to go back and watch the link. You can access that through the Dossier, LinkedIn, or you can reach out here and we'll make sure you get that. Along those lines, many healthcare organizations as well publish information about digital literacy and EHR optimization that I encourage you to look at. So the American Nursing Informatics Association is a good resource for competency frameworks, as well as HIMSS, Health Information and Management Systems Society. They'll provide guidance to support you in the development of digital literacy and EHR competencies. And then, like I said, it's important to also work with educators and informatics teams, because you don't want to just create a 2-hour-long course, like I said, that everybody sleeps through. You want to align with the way those are administered in the topic of the competency to make sure it's evidence-based and then also meaningful. So it's about going beyond just like checking a box, attending a class, but helping nurses understand how to use the technology efficiently and safely in real practice and why they should care. So like I said, I'll be the first to admit that I was not one that cared about digital literacy and using the EHR when I was a brand new nurse sitting through a Cerner course. It just is what it is, right? But if you can align the why behind it, I think that's really important, because we all want to make sure we're providing safe and efficient care for our patients. And then so when you consider all of these things and it's done right, it just becomes a part of your daily culture, and it's not just another training module.
That's great.
Yeah. EJ, do you want to talk about your experience on how like you can leverage early adopters in creating a feedback loop with this?
Yeah, for sure. I think to your point about having the committee, I think that's a great idea, especially when adopting a new EHR platform. I think that making sure that you have like the key stakeholders and people who will be leading teams that are actually using the functionality of the product is really important to make sure that not only the initial implementation and like launch goes well, but also continuing to give that feedback on what could be better because from an implementation perspective, sometimes when we're going into those projects, the people that we're creating these templates with and creating these order sets with and these workflows with are people that are not actually using the product. They're just kind of leading the implementation or the project for the organization, and then they kind of hand it over to the end user, right? So I think that making sure that having people who are going to be utilizing the product on those initial calls to kind of call out certain things, make sure that the implementation is going in the right direction so that once we do launch with the EHR, we can have people who understand what the flow is or what it should be based off of their user permissions or things of that nature. And then also making sure that we're continuing to have that feedback, like I mentioned. So if a workflow is set a certain way to begin with and it's not really working for a certain task, we want to make sure that we're having that continuous conversation so that things can be updated so that the nurses and the end users can work more efficiently within the product itself.
I
So
would
it,
imagine that that team goes a long way also in, because they're able to provide that feedback, they feel more ownership and like, down the road, if something's not working, they can speak up and get it corrected, but then also acting as advocates for using it and how it's made their life better or what have you. I'm sorry, Nicole, I didn't mean to cut you off. Go ahead.
that's a great point too, and that kind of built on what I was going to ask actually. So I know we talked about like early adoption and these feedback loops and how it's like critical to have that sustainability. How do you, as an implementation specialist, get people involved to begin with? How do you identify early adopters? Because I know for me, with my group of nurse friends, when I tell them I'm in informatics, they're like, ah, computers. So how do you get that buy-in at first from your team?
Yeah, I always like to make sure I'm asking like what are the intentions of using this platform, right? Like from my past experience, organizations are moving from maybe one platform to another. I've also worked with organizations that are starting from scratch. So this is the first platform they're implementing essentially. So asking those questions early on, like what's the use case for this, or what's the goal or the intention behind using this new EHR system? Are there things that maybe they experience with another system that they're looking to close the gap on with this system? And then kind of from those answers, I'm able to identify, okay, maybe we should pull in this person from this department or this end user from this like organization so that we are coming together and essentially creating like a working group so that everyone understands like what their role is with that. And I think from there, those stakeholders can go back to their teams and say like, hey, we're implementing this new EHR system, and this is how we're excited about it. Like I think like creating champions essentially is kind of how you're able to also pull other people in to get them excited as well. And I think the more excitement that you create around that, that's how you kind of bring in the early adopters and the people who can then feel empowered, like you said, Amy, to tell others about like how like, oh my God, this new workflow is like amazing
Yeah.
and saved me so much time. And then they're like, oh, I want to see what that looks like. And then everyone just kind of like teaching everyone. So I think that's a really important part of it.
Exactly.
I would imagine celebrating some of those
Yeah.
hurdles, right?
Oh, for
As you
sure.
address those, yeah, as you address those challenges.
Yeah, excitement is contagious, right?
That way it's not like, oh, computers. It's like, oh, this
Yeah.
new thing.
Oh, computers.
Yeah.
Okay, so once these structures are in place, how do you measure whether the changes are really sticking or if old habits are going to creep back in?
Yeah, so I think a lot of times our default is just to look at the outcomes, the numbers, the data from like those EHR analytic tools. And that's important, but I think you also need to look at what's actually happening on the floor as well. Like, are people starting to use workarounds? Do you hear complaints? Um, So in addition to tracking like the data, so these were things like how much time was spent on a specific flow sheet, the number of alert overrides, order entry time specific for physicians. Um, that can tell us one story, right? Like, but it's not the whole story. It's important to be interpreted in context with feedback from frontline clinicians. So an example would be if we worked with a particular department and their documentation time shoots up after we worked with them on a sprint. That might look like a bad thing on paper, like, "Hey, what happened? We're going backwards. We worked with you to optimize your EHR workflow, and now your time has doubled." Instead of just assuming that this is a performance issue, it's important to talk with them, and then maybe you understand that the nurses weren't documenting hardly at all, even the bare minimum to begin with, and now they're documenting what's necessary and doing it efficiently, and we compare that to an expected baseline as a whole, not necessarily from where they came from. So without that context, you might jump to the wrong conclusion and focus your time, energy, and resources on fixing something that's not actually broken. And I think that speaks to why having a clinical expert at the table for these conversations to analyze this data is really important when looking at outcomes. So it can help you determine why the numbers look the way they do. So, like I said, we made a point to talk with nurses during cuddles or rounding to find out what was working well, to hear their complaints, what wasn't working well for them, or even some suggestions for the futures for the future. Hopefully, maybe we have more than one future, I don't know. But sometimes the data pointed one way, but the frontline stories told us something completely different. And building that trust encouraged honest feedback. And sometimes those insights reshaped our approach and how we moved forward. And I think moving from the hospital setting into dossier, the same rings true. So we make it easier for organizations to collect and review competency outcomes and data in real time, things like completion rates, validation trends, and we can help identify where staff may need extra support. But again, those numbers do mean more when paired with insight. So seeing that 98% of your staff completed their EHR training is fantastic, but it's even more valuable when you can map that back to reduce documentation errors, increased reimbursement rates, and improve compliance and improve patient outcomes as well. And for me, that is what makes informatics and computers so exciting. So data is so much more than just a report or numbers on a dashboard that we look at every day. When used correctly, it can tell a story to our teams and our leaders about growth, learning, and impact we make on patient care every day. So that data that Dossier so easily provides to leaders gives a clear window into whether the education and the competency we are administering is truly making a difference. So I've seen our clients use this to, like Amy said, celebrate wins, spot gaps early on, and then keep building on what's already working and maybe reevaluate what's not.
So Nicole, we had a question that got typed in, if I can interject really quickly.
Yeah.
It says, as an end user in a facility, if I see an opportunity for optimization in the EHR, should I pass this information along to the informatics department? I do not want to create more work for them in their already busy schedule.
Yeah, I think that you should. I think it's like we always care about each other. And that's one thing I love about healthcare is we're like a family and we're concerned about the workload of other people. But speaking as an informaticist, that's what gives us passion in our daily work. So while it is maybe a little bit more work for us to look into, it's enjoyable and it's something we want to do. And it comes with real tangible change that can be rewarding, especially when we're not taking care of patients. So like that was a huge adjustment for me. I went from ER nursing where I would have a trauma patient come in cardiac arrest, and I could very clearly see the impact I made on them when we resuscitated them and their family, and even the patient sometimes coming back to thank me. In informatics, you don't see that direct correlation. So it's really important to have frontline staff come to you with ideas and then be able to implement them and then see the outcomes from it over time. So I wouldn't be worried about the increased work, and I would encourage you to get involved, pass that information on, and even participate as a clinical stakeholder, and that can help distribute some of that work as well.
I think that's a great demonstration of the value that the organization places on wanting to improve workflows and I would imagine workload for staff.
I think sometimes it's easy to pass up informatics as something that's maybe not revenue generating, but we absolutely are in through avenues like that. It just is more of an indirect process. And I think it is a huge untapped area that a lot of organizations are starting to look into on how they can improve optimization and what that means for staff retention and turnover and burnout.
Yeah. Just a reminder to anybody, if you have questions, you can either enter them into the question and answer section or just drop it into the chat. Moving along, what's helped your teams feel comfortable giving honest feedback, especially when the data tell a different story?
Yeah, I think this goes along really well with the example I talked of comparing my impact in the ER into informatics. I think viewing it the same way as if we're taking care of a patient, like we build trust with patients by making them feel safe, heard, respected, and instilling that we're instilling confidence that we have their best interest at heart. And I think when we do the same thing internally with our teams, they respond the same way. So building trust with staff starts with the same foundation of empathy and transparency that we have with our patients. So when I worked in the hospital, our EHR analytics showed one unit had much longer documentation times. That was a common theme, of course, right? So on paper, it looked like this was a performance issue and some leadership wanted to pursue that. But when we took the time to meet with the nurses, they explained that their patient population was abnormally more complex in the previous few weeks than it had been. And their clinical workflow just didn't match the reality of their documentation. So by listening first and validating their experience, we realized that it's not a system problem. It's that it is a system problem and not a people problem. So it showed them that it showed to those nurses that their team isn't just a number and that we're looking at the people behind that. And I think, especially in healthcare, it's so easy for us to feel like we're just a number, we're another nurse. And obviously, that's starting to be a problem with all of the nursing shortages. I think there's a few studies that were recently published about the turnover in nurses and how many are wanting to leave the healthcare industry. So I think making sure that your team knows that you view them as a person and not another staff or a number is important.
Yeah.
And I also think it's important to create an ongoing safe space for conversation. And it's not just like a one-time survey, one-time performance appraisal that you look at once a year and then move on. I think being present during staffing and huddles and asking open-ended questions about what's making their job harder and truly listening. And then when staff start to see that feedback, lead to visible change, like fixing those templates or fixing minor workflows, the trust deepens. And it can even be small wins that require very little effort. And over time, that consistency builds that safety that people need to be able to open up and to know that their voice matters.
Very valid points. EJ, is there anything you'd add to that?
Yeah, from an implementation perspective, I think making sure, like Nicole mentioned, having just that open door communication, that policy where the leaders and also their staff feel comfortable giving that feedback. Even back to the question that was just asked by someone in the meeting here, feeling comfortable with sharing your feedback or giving your suggestions or even calling out blockers within workflows is imperative, I think, to making sure that things are getting fixed so that your work gets easier, essentially. So I think from the implementation perspective, if I'm working with leaders on implementing an EHR or a new workflow, always making sure that I'm asking them questions and also letting them know, like, hey, ask your staff how they feel about it, or have like a pilot, maybe test things out to see how that actually flows in real life, and then you can bring that back and we can fix whatever blockers or gaps that are flagged during that process. But just always having that open communication and making sure like you're aligned on the same goal, essentially.
Is there value? And I'm just trying to think of how do you get people comfortable? This is actually question that came in. How do you get people comfortable with speaking up to saying that the workflow just doesn't match reality or something's broken and needs to be fixed? I would imagine that if you're fixing workflows that staff have come to you and said this is a problem, and you share that with people, hey, this got fixed because this person spoke up, you're going to see a lot more people willing to communicate, what their challenges are. But to answer our attendees' question, how do you build a culture where staff feel comfortable saying the workflow doesn't match our reality?
I think that's a good question. I think just even opening the conversation up as a leader, starting to address it, acknowledging the obvious. If you sit down and watch a nurse work, it's really easy to pick up on what is not working well, and acknowledging what you see and asking questions, I think is a really great start. And then mapping it to the culture in general. In healthcare, we're moving towards a like a systems problem instead of a people problem. Even with incident reports, sometimes when they first were introduced in healthcare, people assumed they'd be punitive, but applying the same principles you do in other areas to technology would be beneficial as well. I would say that's my biggest advice is honesty and transparency. Just sit down, acknowledge what's not working well, because you'll pick up on it right away. And I think that builds a lot of trust. I actually have a question for Gear too that kind of builds on this. As an executive and founder of a company, how do you make sure that your employees, or what recommendations do you have from an executive level where your employees feel like it is a safe place to bring up questions or concerns about technology? I
I think
put
it's
you
a
on the
really,
spot.
yeah, I think it's a really good question, Nicole, because um, one thing is saying that, another thing is kind of making that environment, because um, as soon as you kind of voice something that you think is broken or it doesn't work, uh, you are afraid that you kind of make yourself vulnerable, uh, like if I'm inefficient, or like if I'm complaining, like you don't want to kind of brand yourself. But I think all I like to think that organizations and managers and executives really want to know, and I think in reality, I think they really want to know more than people believe. So I think genuinely it's safer than people think. Uh, Probably it's a little bit more kind of afraid of that middle layer of managers, because that, uh, yeah, there are the people really on top. I think they very often want to know more than they can access of information. Um, but I think concept like Magnet is really helping, because they are really pushing hospitals to have structures where you kind of voice improvement suggestions and take action on them. Um, but I think it's hard, but like, well, but I think I like to think that people and most people we meet, when we meet, I I only met like great CNOs, honestly. Like the CNOs we meet, they have been nurses themselves. Like they understand how this is working. So like suggestion and voicing concern, I think is actually way more welcomed than people think. So I think people shouldn't be so concerned. It's very easy to say. It's harder to kind of create that culture. But maybe I can send the question back, Nicole. How can informaticists, like, or the informatics teams out there uh, proactively try to find something, and like basically roadshow departments and tell them like, we want your feedback, because I think that's something, if people ask for feedback and kind of make channels, if you have teams or whatever you use, like make sure there is a way to give you suggestion, uh, because then it's more obvious, it's welcomed.
Yeah, absolutely. I think just making yourself known and establishing those relationships before you necessarily need that feedback is really helpful to begin with. A lot of times, uh, informatics and just IT sometimes are like shoved off into a little corner in their office. A lot of things are virtual or digital just because of the nature of how things have evolved, especially since COVID. So I think getting out there, introducing yourself, rounding when you don't even necessarily have an agenda, starting a Teams page. And so for example, actually at my last job in the hospital, we developed a team page for the ambulatory branch of the hospital where we would have all the super users come in there and they would collaborate together on best practices or things that they've learned that's going well, what's not. And then I would act almost as a moderator, just like Amy is in this panel as well. And that we found that to be extremely successful. And in my current role, I've seen a lot of organizations use forms where it's a collaborative form that both parties, like a preceptor or a leader, educator, fills out with their new hire on feedback about what's going well with the process, specifically with orientation, but you can adapt that to be key topics related to digital literacy as well to facilitate conversations. And
Can I ask a
also,
follow-up?
yes, of course.
So do you think people like we all get surveys all the time, like fill out this, and you get forms and questionnaires. We tend to think that you just do it, no one reads this anyway. What's your experience? Yeah, you have been on the other side of this, like in an informatics role, sending out surveys. How is that being consumed and interpreted on the other side?
I think you have to be intentional with what you're wanting to get out of the form and making sure that anything you create is short to the point. Nurses, clinicians are busy, right? So being intentional about the way it's formatted, making sure it's usable, easy to answer, and then potentially debriefing with certain end users over that form. So that's often what we would do. We would have a few people that would always give us feedback. Of course, it was it was minimal at first because nobody wants to fill out another survey, but when you go back and follow up on some of those answers, people start talking in the department, and then when people realize it's beneficial, then they start filling out more and more.
Yeah. So dual responsibility. Fill it
Yes,
out,
exactly.
and those who receive the answers actually like show that you take action.
Yes, absolutely. And I understand too, you're not always able to take action right away. There's a lot of logistics to making some of these changes, but I think even listening and telling the end user or showing them what you're currently doing, whether that request is being prioritized or evaluated, maybe you're doing a needs assessment over it, like having them involved in the process shows them that there's stuff going on behind the scenes. Yeah, that's a great point and question.
I want to be respectful of the time. We're coming up on the top of the hour. Any closing thoughts? Any additional questions from our attendees? No. Okay. Well, Nicole, thank you for your thoughtful insights into EJ. We appreciate your time. And thanks to everyone who joined us today. EHR optimization isn't just a technology conversation, it's a workforce conversation. At Dossier, we're committed to helping organizations strengthen clinical readiness, simplify competency tracking, and support digital transformation in a way that actually helps nurses do their best work. If you'd like to explore how Dossier can support your informatics and workforce goals, you can visit dossier.com/book-a-demo. On behalf of Gare, Nicole, EJ, and the entire team at Dossier, thanks again for spending time with us today. As we mentioned earlier, we will be sending a link to the recording as well as links to the past informatics webinars that we've had and recorded. We look forward to seeing you at our next session. Thank you again for joining us.
Bye, everyone. Thank you.
Thank you.